Yeah, I think you have a good point there, Doc. One thing we've talked about too is when you reopen things, shutting it down was real easy. That was just like a switch. Opening things back up is going to take uh, more time. And one thing we're concerned about, and I know the whole world is all this protective equipment that it's going to take to now run a surgery case with all your providers and employees in the room and protecting themselves and the patient. So I think it is a multi-level situation that's pretty fluid right now, but the Texas Medical Board will make a determination on that, and it'll be very interesting to see what they roll out here in a couple of days.
Yeah, one more question before we toss it off to the reporters is, I know there was a story come out, I've been asked a few questions on it, the financial situation, the impacts of COVID so far on the hospitals and all hospitals across the state and the country. Russell, do you want to discuss a little bit about the financial situation for MCH and kind of what MCH is doing to kind of help minimize the losses as much as possible?
Yeah, I mean, this situation we've described a couple of times earlier. Just who would have thought that in the world's biggest healthcare situation that hospitals would find themselves struggling? I mean, that's just what it is. It's a struggle. And once the world starts getting back to normal, I think we'll see healthcare procedures and healthcare volumes pick up. I know medical center, our ER volumes are down, our surgery volumes are down, the patient furlough, the employee furloughs, that's things we're having to do. Our directors, including myself, we all took a right off the top, a 10 to 13% pay cut right off the top, just to make sure that this is a top to bottom issue, that we're all doing some part to make sure that we're doing what's best for this hospital, and that's to make sure we're here for our patients.
Deborah, if I can, I'll add a few things to that as well. Our situation is very much the same, and I think I've mentioned to the community before at different opportunities that Odessa Regional is not tax supported in any way. So we're a private hospital, and so we survive through our own revenue streams. And so when your volume is down, like what it is for both Odessa Regional and Medical Center, it is definitely a concern, which is why those furloughs are necessary, as well as cutting other operating expenses where we can. I think one of the other things to consider that hasn't been mentioned yet is, with the economy the way that it is as a result of the pandemic, it's also going to affect hospitals' payer mix. And so patients who probably had insurance a month ago, many of those don't have insurance today. And so we're already starting to see some implications of that as well, even on the significantly reduced volume that we do have. So it's a multifaceted issue that we're working as a community to the best of our ability to address both the needs of taking care of the community while balancing the financial implications of a pandemic.
Thank you, Stacy. We want to get to the reporter questions now. Looks like first on my list I got here Danny. Danny, you have any questions?
No, not right now.
Okay. All right. Below that, Mike Merlot from Odessa American.
Hi. Yeah, my first question is just, have any unrecorded non-residents of Ector County, have any of those COVID patients died in Ector County hospitals since the last one?
Not here at Medical Center.
Okay.
Not at ORMC either.
Okay. Okay. And then, I guess we could start with some other ones. Is there any respiratory therapy or physical therapy for those recovering, whether that be just patients in general or patients who were on a ventilator?
Yes, I can take that. There is specific types of guidance for patients who are having respiratory symptoms on the ventilator. One very easy thing to explain to the public is about how we can turn patients on their belly to improve their breathing. The specific condition that COVID causes, we call acute respiratory distress syndrome. In that specific type of condition, putting yourself on your belly opens up more of the lung volume to be able to exchange air. And so that's one of the things, for example, that we do for patients who are on ventilators in the ICU. Then at the time of discharge, there is some rehab that most of these COVID patients will require just because of the sheer number of days they spent in a hospital bed not moving around. So to get their normal strength back, they need a little bit of rehabilitation, physical therapy. And so that's something that we'll arrange as well.
Okay. And how often is someone from the hospital, both hospitals, reaching out to family of those who are intubated or just those who are in-house?
So at Medical Center, we have our nursing directors and our what we call care coordinators. They visit with the patients and they're with the physicians during rounds. So we reach out to those families and just kind of touch base to tell them that we have visited with their family member, that they're doing very well, and that there's no changes in their conditions, or if the event we have a decision that needs to be made or a treatment update, then we're going over that with the family as well at that point of phone call.
And how often is that?
We do it every day.
Okay.
Some families have said, we're good, you don't have to call my family member, because we give that choice to the patients. But then other patients say, yeah, that would be great if you would kind of let them know. Most of our patients we're finding are in close communication with their families via cell phone or their room phone. So they're wanting to update them on their own.
Right. So with or without COVID, us as a healthcare profession do keep patients as equal decision makers in their health. It's a joint effort between the patient and the doctor. When you come up with a treatment regimen, both people have to be able to work together. So if the patient is unable to have a meaningful communication with the doctor because they're intubated in the ICU, then that next person, the next of kin or the healthcare proxy, is the person that helps make those decisions. So in healthcare, with or without COVID, we're having those conversations as people's clinical status changes, or at least once a day. So that's happening once a day now.
Okay. All right. Then I had a couple more for you. So if a spouse of someone who's been released is asymptomatic, you know, and their partner is released from the hospital, can those family members get a test as soon as they want?
Mike, we would follow the same CDC guidelines for those
Right.
family members. So obviously, household contacts are considered a high risk of exposure. But remember, we are only testing those that are symptomatic in the priorities we mentioned before, priority 1, 2, and 3. So if those people are asymptomatic, then the recommendation would still be stay home and isolate as best as you can. They would not qualify for testing.
Okay. And I know that Dr. Benton wanted to comment on testing at the county commissioners meeting today, but he was turned away because that wasn't on the agenda. Can anyone from the health department kind of speak on what he wanted to say or what update he wanted to give on testing?
Yes, we can have Dale answer that question.
Okay, thank you.
Yeah, Michael, that was an oversight on our part. We thought it was on the agenda, and we've got so much going on that it just slipped through our fingers. But we're going to have an emergency meeting on Friday, I believe, to address that. And it's basically to give us an update on what's going on with the drive-through testing. And we want his opinion to educate the court on exactly what's going on. And so we'll make hopefully a decision on Friday about what to do about the drive-through testing.
Okay. So that update will have to wait till Friday then?
Yes.
Okay. All right. And then
just so you'll know, we're in discussions with a lot of stakeholders about the drive-through to make sure that we can do it. We're close to getting that decision being made as whether or not we can do it as a county, and it's basically a collaboration of a lot of different entities. So hopefully Friday we'll have that answer and we'll give an update to the court.
okay. And then for the hospitals, with our surge still to come, what are things the hospitals are preparing for as far as supplies and personnel? And what are the most pertinent, things for Ector County hospitals that we're looking forward to?
I'll tell you, one thing that we're doing at Medical Center is we are really looking for avenues for the protective equipment. When you see this surge, we want to make sure not only we're protecting our patients, but that our staff are well protected so they can be here the next day to provide the care that these people are going to need. So the N95 masks are high on our list. The surgical masks are high on our list. The gowns, of course, checking those ventilators, making sure they're 100% ready to go. But our protective equipment is very high on our list, just to make sure that our staff are well protected. And Kristen, do you have anything you want to add to that?
No, we're still actually doing our HIMT huddles, which is our internal incident command. And so we review our numbers and our processes. Our teams are still meeting. So every morning at 9 o'clock, we go through those from top to bottom to make sure that we know what's coming in, we know what's been ordered, we know what's been used, as well as what those other teams are producing as we continue to prepare for the surge and the possible recovery of our organization through this.
Okay.
So in addition to all the supplies, the one thing that I'm sure we're all thinking about is also personnel. So there was a question before about furloughs, for example. When we're sending some of our staff home on furlough, we're definitely letting them know that you may be called at any time to come back to help if there is a surge. You may be called not just to do your own job function, but also alternative job functions that could help during a surge. So all our staff is well aware that that's a possibility. So personnel planning is also part of it in addition to the supplies. That's all I wanted to add.
Right, thank you. And then my last question is for the health department. Are there any updates on testing? Brandy, you told me that y'all work closely with Midland Memorial. Is it easier to get a test there, and why?
No, I think it's the drive-through testing that Midland Memorial is doing is what is showing more testing. But from what we've been told, they still try to follow the CDC guidelines, and that's what we are following in Ector County, is the CDC guidelines and people's symptoms.
Okay, so they're still following the CDC guidelines. I remember, a couple of conferences back, there was someone said you weren't sure if they were a little looser with those.
From what we're being told, they are following the guidelines, which the CDC guidelines have, they have changed and they're not as stringent as they were before.
Right.
So from what we're being told, yes, they are.
Okay. Well, thank you.
Hey, Mike, can I make one comment on that?
Yes, sir.
It's important to note for Ector County that I feel like Ector County has performed appropriate testing is what we are after. You sticking by the guidelines from day one for all of us. When you see the test results and the number of positives we have versus the number of negatives and positives in other communities, that our test results and seems to be in more appropriate line with the CDC. And I think we've had a united message from the beginning that we're going to stick with the guidelines. And I think you see that paying off with the appropriateness of the testing that's been done in Ector County.
All right, Mike, you good?
I'm good.
All right, Shelby, you're up next. Oh, I think you're muted, Shelby. There we go.
Now, can you hear me
Now
now?
I can hear you. Yeah.
Like a Verizon commercial. Thank you so much for your time. We do appreciate it. A few questions. Let me start first with a follow-up from yesterday. Dr. Saravanan, this one is for you. Thank you again for your expertise. We talked a little bit about, I guess the short name for it, hydroxychloroquine. Forgive me, I'm no physician. and how some are dubbing that as a wonder drug, as the cure-all. What do you say to people who come in and are like, this is all I need, this is going to cure everybody?
I think my answer is very similar because the only thing that we can depend on is data. And so data is what we'll have to look at. So here's, again, the CDC's website. This specific section that I'm sharing with you today is for healthcare professionals. I don't recommend this part to the general public because they'll need help interpreting what it says on here. But let me show you under therapeutic options, okay? Hydroxychloroquine is listed. Remdesivir, which is an antiviral drug, is listed. And then the convalescent plasma is listed. And there's clinical trials under each one of these that you can go look at. The only one out of these three that currently has an emergency use authorization is the hydroxychloroquine. And that's the one that we are currently using for individuals who are at least moderate to severe risk. But what I do want to explain to the public is that this drug is not a wonder drug, as is no other drug for no other disease process. They are all ways that you can support the body in helping the healing process, but it's not anything that can guarantee that you will have a recovery. So it's like taking an antibiotic for an infection. An antibiotic will not automatically heal your infection. Your body will have to work with the antibiotic also in order to heal that infection. But it does help a lot. At least for an antibiotic, we can be more certain that it'll help. With hydroxychloroquine for COVID, we are not fully certain, but there is enough evidence to say that it is more widely used than not. So that's the one drug for sure that we are using. This again is from the CDC's website. Hope that helps.
Absolutely. Dr. Saravanan, and just for the record, you say that you are using that in ORMC. Do you have any shortages of the drug, or are you having any difficulty obtaining the drug?
No, we currently don't have a shortage. We have a good, healthy supply is the words I like to use. And we have more that's in the books of being able to get if we are to run low.
And
Kristen, sorry, Kristen, do you want to answer for MCH as well?
You read my mind, just what I was going to ask.
Yes, absolutely. For medical center, we're using the same drug combinations that Dr. Saravanan spoke of. We are not in short supply of that at this time, and the physicians are using that for those patients that do need so.
Thank you both very much. Next question, we discussed this a little bit yesterday. We'd just like to follow up for a second. The recoveries for when a patient is being released from MCH and ORMC and they are on the road to recovery, do you test them twice, as I know it's been recommended, or is it more you are no longer symptomatic, your fever has been cleared, you are able to go to bed rest at home, if you will?
So for medical center, we do not, what we do actually is we have a follow-up program. So we call every patient once they go home, if they've been positive within our facility at day 1, day 3, and day 14, to just ensure that they are progressing as we expect them to. Their symptoms are not getting worse, that they are getting better. Following up to make sure that no other family members are exhibiting signs of becoming ill, that they are staying at home, and ensuring that they have the things that they need. And in the event they don't, then we're reaching out to those people to bring them things that they need or help them get what they need to get through the rest of their quarantine.
Okay. And so what, just review, if you will, Kristen, and then Dr. Saravanan for you as well, is it simply a lapse of time that allows someone to be released from the hospital once they are no longer have a fever?
So once their physician determines that they have reached their course of treatment here, and they have progressed to a point that they feel that they can adequately go home and treat themselves, it's all kind of up to physician discretion. just like it would for any non-COVID patient. Once you reach certain points of healing within the hospital setting, then you can transition home and be cared for there as well.
Thank you for clarifying that. I appreciate it.
So Shelby, there is, again, a very clear CDC criteria for discontinuation of the precautions, which is when we would say a patient can come out of isolation or can be discharged home safely, right? So like Kristen said, the doctor would make that decision based on the clinical status of the patient, but there's two strategies to discontinuation of transmission precaution. One is the test-based strategy, and that's basically 2 consecutive tests greater than 24 hours apart. And there is the non-test based strategy, which is 3 days since without symptoms, without taking any medications for the symptoms, and at least 7 days since the symptoms first appeared. So these are what the physicians are following while making the decision whether or not to discontinue.
And last follow-up question, it is up to the physician whether they choose to use the test-based strategy or the non-test-based strategy, if you will, as recommended by the CDC.
Right. It's either or. For now, we do have the tests available, and we are not overwhelmed with the number of patients that are in our facility. So we are using the test-based strategy.
Thank you. To that end, Brandy, this is for you, please. The recoveries you spoke of yesterday, and we're very appreciative that you've been updating the website, you and your team have, with the number of recoveries. Are those recoveries, are you doing purely through the test-based option, or are you doing it through the non-test-based option to classify those people right now, 15, as recovered?
When we review them and we call them and check up on them, when they reach the end of their time, then we will ask them if they have went back to their physician for the test-based. If not, then we do make that recommendation through our health authority with the non-test-based on how we determine if they're recovered.
So is it correct to say you use a combination of both the test-based 2 negative tests and the, if you will, non-test based, the one that is the day, 3 days?
Right, depending on the patient, yes.
And depending on the recommendation of the physician.
Right.
One last question for you, please, Brandy. And we discussed this, I would just like to follow up on it. Online, you've noted that the spread is now, what used to be community spread has been updated to person-to-person spread. Can you walk me through that update, please?
Person-to-person is when we can connect them to confirmed cases. We can connect the links. Community spread would be where we have no connection. We don't know where it came from.
So those ones that were once listed as community spread that have now been updated to person spread, are we saying that there's no community spread in our area with that update? Or is it just you've been able to track every one of those patients directly back to another confirmed case?
Yes, we've been able to track them back to a confirmed case or a cluster that has came from a confirmed case. So that's why they had changed the website to person to make it more clear.
Thank you very much for that update. Trevor, that'll do it for me. I appreciate it very much.
All right, thank you, Shelby. Jared asked his question through group chat, and then Marcos, are you there?
Yeah, but I don't have anything yet.
You don't have anything? Okay. Well, if there's actually one other question that we got from Facebook. And Brandy, you said recoveries. There were 23 recoveries so far in Ector County? Okay, 23 recoveries. The only other question we got, I guess, would be for Kristen and Dr. Shannon was, I've seen something in recent days, I've seen the articles as well, saliva testing, which would be a quicker alternative. Do we know anything about the saliva testing?
We can have Dr. Janaidu. No?
Okay.
No, we don't have any information on it.
All right, Kristen or Dr. Saravanan, do we have any idea about saliva testing?
So I'm not aware of the saliva testing here at the hospital, so I'll see if Dr. Saravan wants to pull something up from
Right.
CDC.
We're not specifically doing saliva testing either. Remember, you're looking for the virus in a sample that you're collecting. The virus affects the lower respiratory system. So the lower you can go into the respiratory system to collect a sample, the better your sample will be. Saliva is the most farthest away from the lower respiratory system. So it would be the least, if a quality of a sample, it would be the least quality sample to be able to send to a lab.
Awesome. Thank you, Dr. Saravan. And any other questions from media?
Yeah, I have a couple more actually. For MCH, is there any update on those 2 patients with the convalescent infusion?
Both patients are still intubated and in critical condition within our critical care units.
Okay, and there's no, hasn't been any improvement, has there?
Yeah, the patients are still critical.
Okay, all right. And for ORMC, I know you talked about you ordered some of those fast-acting tests. Is that correct?
But all hospitals did. So we specifically ordered Cepheid testing machines, and we hope to get them. Fingers crossed this week or next. But again, those tests are in short supply, and if we do get them, our mandate will be to use it for the highest of highest risk patients, which is those people that are hospitalized with COVID disease. So it wouldn't be something that's available widely to the public yet until we get enough supplies to be able to run it widely.
And is that supplies the cartridge specifically that people are lacking? Okay.
That's correct.
Right. That's all I have.
Okay, and we've got one more, Dylan from Fox 24. This just came in. How many beds are available at the hospital with the peak heading? Are hospitals still under capacity? Kristen, I believe we were at 167 average yesterday.
Yes, we're still under our 402 licensed bed count. We're in the 170s, 180s at most at this point in time. Russell, do you want to add anything?
No, ma'am, I think you got it.
It's the same for ORMC. We have not used up even our regular capacity, and we have obviously built for surge capacity as well. So we have plenty available.
Okay, and then we got one question on another Facebook. Have the hospitals been granted IRB approval, or is it required for experimental treatment like the convalescent plasma treatment? I think we addressed, we are starting to use that plasma treatment.
That's correct.
I don't think it's a requirement. I think right now the FDA has got you can get approval per entity, and then you can give that plasma.
Okay. And then Brandy, do we have an expected peak in Ector County? I know it's been discussed before. All we have really is an educated guess, but Kristen or Brandy or Dr. Saravan about a projected peak in Ector County.
You want to talk about it, Pete?
This is Dr. Janadu. We often look at peak, especially looking at New York as the number of ICU or people who are being discharged, because then you have a lag at that point. It will be an estimated, actually it will be a wrong guess to say so-and-so date will be, when you have your peak. What you're looking at is when do you start seeing something bending and, going down. And that is not something that we can predict offhand.
All right, thank you, Dr. Janaidu. Any other questions from media?
I have one. It's Danny.
Hey, Danny.
Once a person is discharged and he goes home, or he's isolated at home, and then after he recovers, is there any recommendations of disinfecting the home?
Well, I can address that a little bit. You don't have to wait till somebody is discharged before you do the necessary healthy and sanitary things. That should be ongoing, but the idea is you are more cautious, you are more aware of what's going on, and to that extent, even before the person, is discharged home, hopefully those who are at home are already, doing those kind of things. And when the person comes home, they just have to keep that, isolation and the social distancing. Working out the logistics, of course, how do you feed that person? How do you put things, across to that person? What kind of, bathroom privileges or bathroom usage in that environment is. So this will be an ongoing, not necessarily when the person is just discharged.
Okay, thank you.
Anything else, anybody?
Trevor, one last follow-up question. I was scrolling through my notes. I wanted to make sure. Dr. Saravanan, I know you were talking earlier about testing and about how we have the 3-tier scheme, if you will, but that you have to display symptoms in order to be tested. Is that still the policy at MCH as well? Is that congruent?
Yes, we're following the CDC guidelines as well for all testing.
So if hypothetical situation, if I or someone were to walk in and say, look, I don't have symptoms, but I'm scared, I want to be tested, will you test that person if they are willing? We've had viewers ask this, I want to be tested, I'm willing to pay for it. Will MCH or ORMC complete that test?
So currently at Medical Center, we are not testing those that do not have those clear definitions of needing to be tested, because we are trying to stay so focused on our CDC guidelines. Due to those number of testing, we're not sure when that surge of patients is coming in. So we're really triaging in regards to who does and does not get tested.
Absolutely. Understand. Thank you very much, Kristen, for clarifying that. I appreciate it.
Sure.
All right, guys, 3:41. If no other questions, we will reconvene tomorrow at 3 o'clock.